Hi, my name is Wendy Winslow. The video you're about to see is designed to help our newly diagnosed breast cancer women, their family members, as well as their friends. It's to help you through your diagnosis in a less stressful way. You will hear about my diagnosis when I went through my surgery as well as my recovery. I will talk to you about how important it is to have support there for you both before as well as after your surgery. You will hear from Sue Joseph, who is also a breast cancer survivor, who has gone through surgeries. You will hear about her history and what she went through and how she made it through. You will hear from Dr. Bruce Topol, who is a reconstruction plastic surgeon, and he will show you the 4 surgical procedures that are most commonly used, remembering that not all doctors use the same procedures for all patients. It's up to your doctor to recommend what's most fit for you. You will meet Victoria Blight, who is a nurse practitioner. She will talk to you about the pre-op as well as the post-operative part of the surgery and teach you how to get through it in a smoother way. We recommend that you get your family members together and your friends to watch this video. It's important that you write down all the questions that you have, so go ahead and get a pad of paper and a pencil. Feel free to stop the video at any time. If you can think of any questions that you want to ask your doctor, go ahead and write them down while you're watching this, and then you can bring it into your doctor later. So go grab some popcorn, get your family members and friends together to watch this video, and it'll help you get through a smooth recovery. At the age of 33, I was diagnosed with DCIS, ductal carcinoma in situ. I was told that I had to have a mastectomy. I had a really hard time in dealing with it because I remember when my grandmother had a mastectomy and nobody wanted to talk about it. I wanted to make things different with what I went through and talk about it openly with my family members, my nieces and my nephews. I remember all the sadness that was around my family. We had a lot of anger, a lot of denial. Nobody wanted to talk about it. Nobody knew how to talk about it. I decided to go and get my friends at work involved because they were my support group. And I did what I needed to do to help me through this in a stronger way. We were all scared on what I was going to have to live through. Would I ever be feeling whole again? Would I ever feel normal again? Could I live with this? Would somebody else accept me for the changes that I had to make in my life? And will they accept me for who I have now become? There were a lot of questions and not much time to be able to have them all answered. So I kept going in with all kinds of questions to my doctor and making sure that I understood what I needed to know and had to go through the surgery. When I was diagnosed with DCIS, I ended up meeting a bunch of survivors, and Sue Joseph was one of them, and she's now a good friend. Sue, hi.
Hi, thank you, Wendy, and thank you for doing this video. I think this is a great thing you're doing for community service. My name is Sue Joseph, and I remember being diagnosed the day the doctor called. It was a Friday afternoon, and those words coming through the phone line, "Yep, Sue, you've got it. Ductal carcinoma in situ." Words at that time I didn't know what meant, but as time goes on, it was an education that we all learned very quickly. I'll never forget that, and my life as I knew it changed forever. Living your life at full speed, full throttle, kids, soccer practice, cooking, laundry, you know, working full time. And just all of a sudden the brakes hit, life stops, life changed. After that phone call, I called my husband at work while I waited for him to come home, finished up a few things. I think I just collapsed to the floor in tears for a few minutes. I think that was all I allowed myself, and then I thought, you know, okay, time to finish the laundry. You know, that's how my priorities changed. And You know, but you start wondering all those what ifs. Who is going to do the laundry? And at the time, I was feeling really healthy. How could I be sick? How could I have cancer? And would I get sicker? And I went through an awful lot since then. I've done lumpectomy, mastectomy, chemotherapy, radiation, stem cell transplant, and you get through it, you do it. And so this is a great video. There were a lot of questions I had at the time that I went through it, and I know that this will help all of you out there as well. Yeah. So thanks again.
Thank you.
Okay.
Dr. Topol will now show you the 4 most common surgical procedures that women are given the choice of.
I'm Dr. Bruce Topol, and I'm here to demonstrate various forms of breast reconstruction using Vicky. Let's begin first, and we'll talk about tissue expander implant exchange technique, which is an operation, actually a series of operations. There are 4 total, 2 of some size, and the other 2 are very small, to reconstruct the breast. At the time of the initial mastectomy in a so-called immediate reconstruction, which is the most commonly performed type of reconstruction, although your surgeon may do it on a delayed basis, the surgeon removes the nipple and the circular areola. We try to minimize the amount of skin excised nowadays in so-called skin-sparing mastectomy. So we wouldn't remove as much of this skin relative to the size of the breast if we didn't have to, trying to save as much skin as possible. So at the time of the mastectomy, the surgeon removes the nipple and the areola in almost all situations, but not totally all situations, and the underlying breast tissue in terms of the mastectomy. Now, the plastic surgeon then comes and dissects underneath what is simulated here as a pectoralis major muscle. We lift that up and elevate it superiorly and towards the midline and out to the side to a variable extent, occasionally elevating some muscle underneath, occasionally not, and using a different material to support the underneath portion of the reconstruction. But in any event, under the muscle, one places a silicone rubber shelled saline-containing tissue expander, which is a temporary device that has a one-way valve. At the time of the mastectomy, we would inflate that expander to a variable amount, depending on factors related to the muscle and the skin, and then close the incision. A drain is placed, draining the pocket created for the breast reconstruction, and if more than just a sentinel node, if several lymph nodes were removed from the armpit, a second drain might be placed in the armpit area. One normally waits 2 or 3 weeks, depending on various factors, and then one would begin in the office tissue expansion to fill that balloon up to an appropriate level. If the patient is going to be receiving radiation therapy or chemotherapy, my practice is to try to have that inflated before the therapies begin. There are many plastic surgeons who feel that the reconstruction might need to be delayed if there's going to be radiation therapy. That's a current area of controversy in plastic surgery, and good arguments can be made both ways. But assuming that the expander is in at the time of the initial mastectomy, it's inflated beginning about 2 or 3 weeks after surgery, a week at a time until the appropriate level of inflation is made. At that point, a second procedure is done, also under general anesthesia, but as an outpatient normally, where that incision is reopened. The tissue expander that had been placed under the muscle is removed, and an implant is placed. Now, currently in this country, these are mostly silicone rubber saline-filled implants simulated by this material. However, currently there is increasing the opportunity that we may be allowed to use silicone gel implants, so-called cohesive gel implants. Older implants had the consistency of a syrup on the inside in terms of silicone. The newer gel implants have the consistency more of jello or marmalade. So if one cuts into that implant, the material wouldn't ooze out, it would pretty much stay where it is. In any event, an appropriate implant is placed. Now, implants can be round, much as are done in breast augmentation cosmetically, or they can be so-called contour profile implants, which really are implants that are wider than they are high, that on profile would simulate so-called mature breast profile, where there's not so much fullness here and there's more fullness down inferiorly. So the implant then is placed in this pocket that's already been created with the stretching from the tissue expander to simulate the appropriate volume and shape of the breast in that second procedure, and the incision is again closed. Now at the same time, there may be some surgery done on the opposite breast to make it larger or smaller or lift it. Federal law allows all women to have surgery done on both breasts to achieve symmetry of size and shape and volume. So women are protected, and their insurance companies are required by federal law to allow this. After the second operation, the patient recovers. If they have had radiation or chemo, that second procedure, placing the implant, is usually delayed until after all of that has taken place. But after placement of the implant, a period of a month, sometimes more, sometimes less, goes by, and the nipple can be created, either using local tissue or occasionally sharing some from the opposite nipple. A small procedure under local anesthesia as an outpatient, either in a minor procedure room or office setting, depending on your surgeon's preference. And a month or so after that, the circular areola can be reconstructed using tattoo to try to match the opposite side. If this is a very large areola, some of that areola could be removed to share over here. Or an older technique, which still works well, is to take skin from the groin area, because it's darker, and place in a circle over here to reconstruct that areola. And that would complete the 4 procedures done for tissue expansion implant exchange. Sometimes those procedures are combined to just 3, where the tissue expander isn't placed initially, but the implant is placed initially. There also are implants that can be used as a quasi-tissue expander. They have a valve that can be left in, or a fill tube, so that the implant can actually be adjusted a little bit, thus obviating the need for 4 procedures. Then there would be just 3, placement of the implant, adjustment as an outpatient, and then the nipple, and then the areola. But the standard classic is the 4 operations: tissue expander, then implant, then nipple, then areola. And that would be how the breast would be completed in that technique. The technique has advantages of it's a shorter, faster, easier set of surgeries on a patient than using their own tissue. The downsides are it's an artificial material, it's firmer, it's more forward projecting, it's less natural in its feel, and if infection occurs, the device usually has to be removed, in which case you've lost all that expanded tissue and things flatten. But it does avoid the longer procedures of using the patient's own tissue. All right, let's discuss latissimus dorsi reconstruction, which is a technique, an older technique, but still a very good technique, that involves the use of skin and muscle from the back to reconstruct skin and volume of the breast after mastectomy. Occasionally, the muscle and the skin are enough to reconstruct an adequate amount of volume. Nothing further is needed. Occasionally, an implant may be necessary. Occasionally, at the time of the initial reconstruction, with the latissimus muscle, an expander is used, and I'll illustrate what's involved. The general surgeon would remove, again in a skin-sparing technique, the nipple and the areola around it, trying to save as much skin as possible, and of course the underlying breast tissue, which Vicki demonstrates here in the terms of the mastectomy. That leaves a cavity with as much skin as possible here. The patient is then rolled usually on the side, occasionally slightly more than the side, but we'll have her go all the way on her back so you can see what we do. There are various incisions one makes on the back, occasionally on an angle like this, occasionally up and down right near the back side of the armpit, and occasionally transverse or sideways right in where the bra line is to try to hide the scar, because the scar back here is usually not very good. It tends to widen. But skin, to a variable extent, and the underlying muscle can be dissected or lifted off from all the other muscles below it and around it, such as this. In the case of not a free tissue transfer, but leaving it attached right here, this muscle and skin are then placed through a tunnel that goes underneath the skin of the armpit to then communicate with the mastectomy. This incision is closed. It's a difficult incision. Fluid can collect here. It can be a long scar, depending. And 1 or 2 drains are placed to drain this area. The patient is turned back onto her back. And this muscle is then brought through this pocket, oriented appropriately, and whatever amount of skin is necessary is then used to reconstruct the amount of skin that was resected at the time of the mastectomy. If the breast is small enough and the muscle is robust enough, no implant or expander will be necessary because the muscle will make up enough volume to reconstruct a breast of appropriate size. If the breast is large enough or the muscle was not robust enough, then at the time of this surgery, a tissue expander can be placed to occupy some space, a saline-filled silicone rubber shell that can be filled totally or partly at the time of this surgery, and then left for secondary reconstructions, or an implant can be placed at the time of this surgery, if necessary, to reconstruct the breast of adequate volume compared to the opposite side. And then this circular incision would normally be closed sideways or transversely to complete that reconstruction. Again, a drain is placed, and if armpit lymph nodes were resected to any great extent, then a drain would be placed here as well. Patients normally stay in the hospital for 1 to 3 days. The drains then are removed normally here in 3 to 5 days, the armpit the same. And the back drains can stay in for quite a while, sometimes 1 or 2 weeks, because this area tends to drain more on the back, one of the complications. If the patient had a tissue expander, then that would be slowly inflated in the office. If the patient had an implant, nothing further would need to be done. If there was a tissue expander, then a second procedure would be necessary to reopen this incision, take out the tissue expander, and place an implant of appropriate volume to reconstruct the breast of the appropriate volume compared to the opposite side. If that second operation is necessary, taking out the expander and placing the implant, then at that same operation, adjustments can be made to the opposite breast to make it larger, make it smaller, or lift it to achieve symmetry of size and shape. Assuming the symmetry of size and shape has been completed, then at the time of the second procedure, if the implant is necessary, or if there was no implant, then the second procedure would be to make a nipple, which can be done again sharing from the opposite side or reconstructing with native tissue, and then tattooing an areola or using a skin graft from the groin, or taking, if there's a very large areola, from the other side. Now, there are ways to combine making the nipple at the time of the original surgery to do a one-stage reconstruction, which are done by many people, but in general, if one was to do the conservative traditional approach, it's the muscle flap plus minus an implant or an expander, and then make the nipple, and then adjust and make the areola. But again, your surgeon may combine this in as many as 2 total or even 1 total operation. There are people who do that. Well, let's discuss the TRAM flap, capital T, capital R, capital A, capital M. Stands for transverse rectus abdominis myocutaneous flap, a very clever procedure that is quite amazing in the fact that it works, in my opinion. And I'm amazed every time I do one. It involves, if it's done immediately at the time of mastectomy, but also can be done on a delayed basis as any of the other reconstructions can be done. But in the immediate situation, it's done the same time as the mastectomy. The nipple and the areola are removed contiguous with the underlying breast tissue in terms of the mastectomy. The lymph nodes are sampled or further removed depending on the indications. And in this pocket, as much skin is saved as possible, so-called skin-sparing technique. What one does with the TRAM flap, there are 2 basic ways to do this: Pedicled TRAM and free TRAM, and we'll demonstrate both. The Pedicled TRAM procedure, one removes an adequate amount of skin, depending on the amount of excess skin the patient has, normally from the upper level of the belly button down to the groin area. There are situations where one removes tissue in the middle of the abdomen or even sometimes in the upper abdomen, but the traditional common TRAM flap involves skin from the upper border of the belly button down to just about where the pubic hair starts, and there's an ellipse or football shape of tissue. Now, it turns out, amazingly, that there are a series of vessels that can supply about 2/3 of this ellipse of tissue. And they run down the course of one of these 6-pack muscles or rectus muscles. There's a vessel that goes from the top down, and there's a vessel that goes from the bottom up. and both can be utilized depending on the technique of TRAM. In addition, there are certain specialized techniques that involve just a small connection of one of these vessels in the muscle to minimize resecting the muscle. That gets a little bit more complex, and that involves free tissue transfer of a very specialized blood vessel. We'll today just discuss the typical pedicled and common free tram flap using Vicky. Now, we would like to save the belly button. So the belly button is circumscribed. It's actually a trumpet or tube-shaped scar, is all that the belly button is, and we cut around it and save it, if at all possible. So that stays with the patient. This ellipse of skin is removed, and it stays connected to, in the pedicled TRAM situation, the muscle, one of those two six-pack muscles that run down each side of the belly button. And we'll simulate here the skin and underlying fat and connection to the muscle. So one lifts up all of this skin all the way up towards the chest, just as in doing a tummy tuck, but there's an artery and a vein, very specialized, that flow from the top down, also from the bottom up, which we'll get to, that feeds not all of, but roughly 1/2 to 2/3 of the skin and fat of the abdomen. And in many women, that's all that's necessary to reconstruct the volume of the breast. So this skin and fat is connected to the muscle. All the other tissue is freed up. Some people take all of the muscle, some people just take a portion of this muscle. But in any event, a tunnel then is created above the muscle and under the skin that goes all the way to the mastectomy site. And all of this tissue is transferred into the breast pocket, still connected to that muscle. Then, here's our skin and our subcutaneous tissue connected to this muscle, which is supplying the artery and vein that feed everything. And one has to be careful not to twist or kink that very specialized muscle. Then, at least half and sometimes 2/3 of that tissue can then be folded and molded in various different ways to fill the skin and reconstruct the breast. See if we can dunk all this back in now that we've pulled it all out. How much is used? It depends on the size and shape of the breast. So we have saved the subcutaneous fat and just a circular amount of skin in this situation to reconstruct this breast of adequate size. At that same operation, one can do some work on the other breast to lift it, make it bigger, make it smaller, or one can do that at a second procedure, which happens to be my preference. But there are many ways to do that. And then one has to close the abdomen and close up around the breast. All that's showing is just a circle of skin. This is all native breast skin otherwise, and that circle of skin used to be here in the abdomen. Now the gap for where the muscle was taken, and there's various ways to do this, various amounts of gap can be created, are sutured together. Occasionally some surgeons prefer a piece of mesh material to cover this area because weakness or bulge or hernia can occur where the muscle was removed. The belly button has been saved. We then flex the table and bend, flex the patient, and these hooks will simulate closing that abdominal wound. And the belly button is brought out through a new hole at an appropriate level, so we don't lose our belly button. And there's a drain and a drain normally, and this incision is closed down right above the pubic area, similar to tummy tuck, to hide it as much as possible in the traditional TRAM. Again, there are higher resections where the scar might come right across the middle or even higher up, but this is the traditional situation. Drains are placed here and here, and drain is placed for the breast. This is a larger operation than the tissue expander implant technique. It's a bigger procedure. You don't use anything artificial. It's the patient's own tissue, so the breast looks and feels quite natural. Riskier, a longer stay in the hospital, more discomfort to recover from, and it takes a lot of cooperation between the patient's support system, and the plastic surgeon to get the patient through this procedure. But when the patient has adequate skin and fat to reconstruct a breast of adequate volume, it's an excellent technique, more complex in diabetics, more complex in smokers, more complex in obese people, but certainly can be done, therefore avoiding any artificial material. In the so-called free tram, and there are variations as to how specific a blood vessel one uses, if it's done at the time of the mastectomy, again, immediate reconstruction, the nipple and the areola are removed along with the underlying breast, saving as much skin as possible. But in this situation, the belly button is saved. The skin and underlying subcutaneous tissue are fed by that same muscle. But it turns out that that muscle has a very, very strong circulation from below compared to from above. From above, we use that blood vessel and that muscle to reconstruct in the Pedicled technique. But in the free technique, we actually remove the muscle and divide it completely above the level of belly button. And we remove it below also, but we save the blood vessels down here. We thus have skin and underlying subcutaneous tissue. Again, we can normally use about 1/2 to 2/3 in the free tram, a little bit more than in that pedicled one that I just showed where it was connected. It's actually free. And right now there's no blood supply or circulation to the skin, the underlying fat, and this little bit of muscle. The tissue is then brought as a unit up to this breast pocket, and an appropriate artery and vein, either in the armpit area or occasionally from the chest wall, are isolated, and using very high-powered magnification, either worn as magnifying glasses or with a microscope, the artery from the lower portion of the muscle is connected to an artery in the chest, and the vein to the vein, or also can be done in the armpit area, to now breathe new circulation into this tissue. The tissue, again, is folded and molded to fit inside the skin to reconstruct a breast of adequate volume. The abdomen is then closed, as I showed you before, with saving the belly button and bringing it out through an appropriate hole. The advantage to the free tissue transfer is you can normally take a little bit more of this tissue, a little bit more than half, maybe as much as 2/3, and you are able to reconstruct with a little bit more volume. And by not taking all of the muscle, there may be a little bit less in terms of weakness, bulge, and hernia in this area. A disadvantage, it has to be done by a team very familiar with microsurgery, and so it's only done in certain places. Again, the closure of the abdomen is similar, and the drains are placed as before, also up here. A lengthy operation in skilled hands, done very well with a high success rate. A similar stay in the hospital, it's usually 3 or 4 days. And then at a later stage, normally, there are some people who are more aggressive, but at a later stage, normally, the nipple is reconstructed, and the areola is reconstructed, and the reconstruction is completed. Again, avoiding the implant and the expander and any artificial material. A little bit about postoperative garments. There are many different types of bras that are used immediately after surgery. Some people don't use any bra at all. I don't the first several days after surgery, but once the patient is home, and some surgeons immediately will use a bra similar to this. The kind I do use when I do has cups already built in, but in any event, it's a garment of some consistency for support. It usually has a zipper in the front and several fasteners. These are normally Velcro, so it's real easy to take on and off and launder. Some type of bra is often used after breast reconstruction. Again, I don't immediately, but some days after surgery when I know everything is well, I'll often use either a bra like this or just a nice sports bra that's comfortable, not real binding, and allows the tissue not to be compressed. But one doesn't have to be in a difficult, cumbersome harness for very long, if at all. There are a variety of sports bras that are made, light, cotton, easy to wash, and these are used. The drains can come out, safety pin to the front of the bra, and it allows someone pretty good comfort and flexibility as they're recovering, because the difficulty is the incisions, care of the incisions, and care of the drains. Things are much easier when the drains come out, and then much easier as the incisions heal. I happen to use stitches that dissolve so we don't have to pluck out sutures. I think most people probably do, but again, your surgeon may use a different type of suture material. Some bras afterwards, either the stronger zipper kind or even a very nice easy sports bra, cheap, easy to find, easy to wear.
Vicki will now give you some helpful hints prior to surgery and show you what to expect after surgery.
Hi, my name is Victoria Blight. I'm a family nurse practitioner and I cared for Wendy during her surgery. Today I'm going to be reviewing with you some of the important points to remember when undergoing mastectomy with tram flap. Some tips for the period before surgery. First, get educated. Talk to your surgeon. Feel comfortable and informed about your options. Have a friend come with you to your appointments with your surgeon. Bring a list of questions so you don't forget things or feel overwhelmed. Second, assess your support system. Make people aware of what's happening to you. Ask for help and learn how to accept it. Make sure your family and friends are involved and aware. Like Wendy said, they are going through this with you and they need to be informed so that they can support you. 3. Getting ready for surgery. Talk to your surgeon and your anesthesiologist ahead of time about what to eat or drink before surgery, or whether you should or should not take your medicines. When you meet with your surgeon and your anesthesiologist, bring an up-to-date list of your medical history, your surgical history, all of the medicines that you're taking, including over-the-counter and herbal supplements. They will tell you whether to take them the morning of surgery or hold them. Try to drink plenty of fluids in the days prior to surgery. If you have a living will, bring this with you to the hospital. If not, when you go through admissions, they'll likely help you to create one. What to bring. Find out what's provided for you at the hospital. Usually they're going to give you the basics, a toothpaste, a toothbrush, comb, but it's really nice to bring your own toiletries from home. Make sure you bring a comfortable robe, a comfy, roomy outfit to go home in, slippers, and definitely a comfortable pillow. I will now review for you some of the general expectations for your hospitalization. Generally, prior to surgery, you'll be asked, as I said earlier, to hold food or water for about 12 hours. Your anesthesiologist will confirm with you how long that period needs to be. The day of surgery, you generally will be admitted through the main admissions of the hospital. They'll take you to the pre-op area where a nurse will give you a Johnny. At that time, usually they'll start an IV to give you some fluids. They may give you some medication to relax you at that time. In addition, you might meet with your anesthesiologist and your surgeon at that time, and generally your family members can be with you. Expect that surgery is going to last anywhere from about 4 to 8 hours. When you return from surgery, you're going to be in the post-anesthesia care unit. There, a nurse is going to be monitoring your vital signs frequently, and what I mean by that is your blood pressure, your pulse, your oxygen level. They're going to be assessing your pain frequently. When they feel that you are not too groggy, that you're comfortable and your vital signs are stable, at that point they're going to bring you to the surgical floor where you'll be for the rest of your hospital stay. When you awaken from surgery, you will still have your IV. You may have oxygen in your nose until you're more awake. You will have a Foley catheter in your bladder so that you will not need to get up to use the bathroom the first day of surgery. You may have tight elastic stockings on your legs, and possibly inflatable leggings called sequential TEDs. These are used to improve circulation and decrease your risk of a blood clot. After surgery, there are many options for pain management. Most women will have an epidural. This is a small catheter inserted into the spine which delivers narcotic pain medication. Other women will choose to have a PCA, or patient-controlled pump, which allows women to medicate themselves as needed. Other options include IV medications, an IM or shot form of medication. By discharge, you'll be taking oral pain medicines. These medications are meant to keep you comfortable postoperatively. The nurse will frequently assess your pain. Be sure to be honest about your pain and do not be afraid to speak up if you need extra medication. It is important that you're comfortable so you can gradually increase your activity and begin the healing process. Some of the pain medications may cause nausea or itching. Be sure to speak up if you have either of these side effects. There will be medication available to help you. When you have abdominal surgery and anesthesia, your bowels can slow way down. Because of this, you will start with only ice chips after surgery. As you have more bowel sounds, your diet will advance to clear liquids such as jello, juices, and broth. If your diet is advanced too quickly before your bowels are ready, you could develop nausea and vomiting or a bowel obstruction. Once you're passing gas, you'll be able to resume a regular diet. Make sure at this point you focus on fluids and fiber, as pain medications can be constipating. When you return from surgery, the nurse will reposition you frequently. This will prevent skin breakdown and postoperative pneumonia. The position recommended while in bed is that where your head is elevated to 30 degrees while a pillow is placed under your knees. This takes some tension off of your abdominal incision. You will not be repositioned onto the side that you had surgery. You will be encouraged to pump your ankles to improve circulation while in bed. You will be encouraged to get out of bed as soon as possible and start walking. Because you've had medication, you may feel weak and should not get up unattended. When getting out of bed, it's best to roll onto your side and elevate the head of the bed. Dangle for a moment at the bedside before standing. When walking and standing, bend slightly at the waist. Again, I will reiterate the need to keep up with your pain medications. You do not want to realize you need some medication while you're trying to get out of bed. It will limit your ability to heal and move ahead. The nurse will encourage you to get out of bed frequently and ambulate in the halls. She will provide the majority of your care initially with bathing, etc., and gradually encourage you to independently care for yourself. You will not be able to shower until your drains are removed. A nurse or a support person will help you with washing. You may have the Foley catheter we discussed earlier for 1 to 2 days. When it is removed, a nurse will help you to ambulate to the bathroom. You will have drains as we discussed earlier. When the drainage in these drains slows down, they will be removed by the surgeon. While you're in the hospital, a nurse will care for these drains, emptying them and recording amounts. You will be instructed on how to care for them at home if you will be discharged with them. While you're in the hospital, make sure you take time to rest. Limit your visitors. Let your nurses know when you need to rest so they can restrict visitors and phone calls. You will be recovering from major surgery and your body needs rest to heal. You will have a large, loose-fitting bra on over multiple dressings. If you've had a tram flap procedure, you will have a large dressing on your abdomen from hip to hip. You will have 1 drain per breast and 2 in your abdomen. These small drains, called Jackson-Pratt drains, will be maintained and cared for by the nurses. Prior to discharge, your surgeon and your nurses will spend time educating you about what to expect postoperatively. When you go home, you may still have your drains, and if you do, they'll instruct you on how to empty them. You may keep your incisions open to air, or you may have them covered with dry, sterile dressings. The surgeon will tell you which is most appropriate before you get sent home. Likely you'll be wearing that bra that we showed you earlier, and you'll probably be wearing that consistently for about a period of 3 to 4 weeks, depending on what your surgeon's recommendations are. You will be instructed to monitor your breast for changes in color or warmth. It can take about a full year before the breast forms into what it will be consistently. It also often will lack sensation, and your surgeon will talk to you a little bit more about that as well. You'll be advised to look for signs of infection. Any foul drainage, increased warmth, redness, or temp above 100.5, you're going to be instructed to call the surgeon immediately. You'll need to eat healthy postoperatively. This is not a time to go on a crash diet. Your body needs nutrients to heal, so try to get a wide variety of fruits and vegetables. As I had mentioned earlier, it's also important that you really push your fluids and your fiber, because some of the pain medicines and surgery itself can create constipation. You will not be able to drive for about 2 weeks after surgery. Your doctor will advise you not to lift anything heavier than 10 pounds, also to avoid reaching or pushing or pulling anything heavy. Most importantly, rest. You've just had major surgery. You've just been diagnosed with cancer. You're probably going to be undergoing some kind of radiation or chemotherapy. You're going to be tired. You need to be open with your family about this, because even though you may look like you're healing on the outside, you're probably still pretty run down on the inside. Make sure you're open, as I said, with your loved ones about that. Lower your expectations of yourself, and also ask others to curb their expectations of you. After all you've been through, it's very normal to experience a wide variety of emotions. Some people feel anger or sadness. People even experience depression. Be honest with your feelings with yourself. Make sure you're very honest with your feelings with your family. And consider personal and/or group counseling, which many women have found very helpful.
Next you will meet my sister Meredith, my nephew Greg, and my niece Rachel, and they'll talk about the effect that my surgery had on them.
Hi, I'm Meredith Birkland. I'm Wendy's sister, and when she was diagnosed with breast cancer, when we first found out, I just thought, she's been through a lot already. She didn't deserve to go through this. Not that anyone does deserve breast cancer, but it was really tough. And we were reaching out to her as best we could. My kids were really young when she was diagnosed, so I felt bad. I was working and I had small children, and I didn't think that I could be there enough for her to help her through this, but I talked to her on the phone. We visited her in the hospital, and after she got through with the surgery, I thought, you know, she should come stay with me and the kids, you know, so that she could recuperate. But all her doctor's appointments were in Manchester, so she couldn't really do that. She needed to be closer to the doctors. But I felt bad. But when Wendy started to feel a little better, she told me that she was glad that I was there for her, that I was a big help. But at the time, I didn't think I was very much help at all. But we were, I guess, a lot more than I thought. We talked on the phone almost every day, and we came to see her in the hospital, and when she was feeling a little better and feeling up to it, we came and took her out to dinner. So that's what people have to remember, is to just, you know, always reach out. You know, cancer isn't catching. You can't catch it like you can a cold. And so just remember to always be there and reach out as much as possible. And, you know, and even though my kids were little, they still, you know, understood what was going on. So, like my son, Greg.
My name is Greg Birkland, and I am Wendy's only nephew. Wendy was the person that was always there for me, supported me. So when the family found out that she was diagnosed with breast cancer, I was very down and sad. Didn't know what to expect would happen, and I didn't know much about breast cancer until Wendy announced how it's caused, and she ended up making dolls, and I was
showing you the doll.
Yeah.
As it was going through the process.
It wasn't very mature then when I was that. Yeah. So I was kind of like, whoa, about it.
A little grossed out, huh?
Yeah.
Hi, I'm Rachel Birkland. I'm Wendy's niece, and I was very young when I found out that she had breast cancer, and I also didn't know much about it. And Wendy definitely taught us a lot about breast cancer, and we visited her a lot in the hospital and
at home.
Yeah, and at home, and we gave her some presents to make her feel better, and I was very glad that she was okay when she was done with all the cancer stuff.
Mm-hmm. Well, one of the things we learned is that when you're a family, you need to reach out to people, even though it's scary, and the kids didn't really understand all that was going on, but that was okay. We all learned together, and that it doesn't just affect the person with the breast cancer, it affects the whole family. My parents were very scared, of course, and my kids were scared, Wendy was scared, but as long as we kept talking about it, we all learned together, and
we were all there for each other.
We were all there, right? We were all there for each other, and that's what it's all about, just making sure that you don't get so scared that you crawl into a hole, and that you don't forget that the people around you still love each other, and that we all need each other, and that's how you get through it together, is to keep talking about it and reaching out. And she still wanted hugs and kisses, and still could go out to eat with us when she was feeling okay on the good days, and on the bad days we just called and talked and let her know that we were there for her.
She got a chance to just be free from all that stress and just have some fun.
Yep.
I remember, Wendy, when I was first diagnosed, and just wishing I could get through all this unpleasantness and put my life on fast forward. And at the time, just going through it day by day, the support that I needed, family, friends, finding strength from within, and trying to get educated, and it just going through it. Your life was crazy, a lot to absorb, and coming through afterwards, looking back a year after, and just how much my life has changed. Earlier I mentioned how much it changed, and I'll tell you, it's made my life more positive. I do not take the small things in life for granted anymore. Family is so important. You know, my priorities before, laundry and whether the house was clean, it's like, who cares?
Right.
I am a different person. I'm stronger inside somehow. I'm a little wiser, a little smarter, a little older, a little more mature. Yep. Life is precious, and so are you. And I wish everybody out there the best of luck with viewing this, and good luck to you. And forget the laundry.
Yeah.
What do you think?
Yeah, I remember when I had gone through it, it was hard, but I had a lot of support from my coworkers at the hospital. They were always there for me. We could talk about whatever, anytime. My family and my friends were a lot of help too. We found a support group that was at the hospital, so that if you wanted to talk to survivors that were there for you, you could. They'll tell you what they went through, and they would support you in whatever way that they wanted to. I remember it was nice because my church got together and helped me with the meals, because it's
big.
hard. It's when you've gone through a surgery, it's hard to be able to live a typical day, because
And you have to eat healthy.
Yes, you do. Yeah, you have to watch what you're eating and take care of yourself better. Yeah, and I had a really hard time in dealing with mine, because I wasn't sure I could deal with it all. And so I actually went for help. I had a counselor that was a breast cancer survivor, and she helped me deal with it so that I could move on and become more positive again, and be thankful for all the small things that I do have, because when this kind of thing happens to you, everything else is very minor. It's a big battle to go through, and you really appreciate what you have in the end.
Absolutely.
Yep.
Absolutely.
Yep.
And there is an end.
There is.
There is an end.
There is,
and
it's nicer.
Yeah. So
Yeah.
you get through on the other side, and I'm telling you, you
And
can
you
just
make a lot more new
yeah.
friends.
So we can go shopping for a new hat
There you
and
go.
forget the laundry.
Living through breast cancer is not something we get over. It's something we find a new way to live with.
We hope this video will help you, your friends, and your family help you to recover faster, better, and stronger. Good luck and God bless. At the end of this film, you'll see some resources that will help you. Thanks, everybody. Bye.
Bye.